So I think that one thing that is important to understand is that they are different biomarker, right? Like they are the PET biomarker, they're a fluid biomarker, and they don't measure the same species of amyloid and tau. So in Alzheimer's disease, we have two proteins that we find in the brain of people living with Alzheimer's disease. So one is amyloid, so in the form of plaque, and then the other one is tau in the form of neurofibrillary tangle. And the PET scan allow us to really capture these form of the protein that we find in people with Alzheimer's disease dementia, right? So these markers are actually extremely good. So unfortunately, in a study that we showed, cognitively normal older adults that were positive both in an amyloid PET scan and a tau PET scan, if followed over 5 years, all of them actually develop cognitive impairment. So, and about 40% of that group getting a diagnosis for Alzheimer's dementia. So this is for the PET biomarker. The fluid biomarkers, let's say the plasma, the blood biomarkers, they are absolutely great as well. I mean, it's so incredible actually to have a blood biomarker that can capture the pathology. The only thing is that they're not as specific, so they don't capture the same species of amyloid and tau. It's the soluble form. And what I was actually showing in the plenary is that there was a paper that just came out a few months ago where they showed that in newborn baby, the p-tau217, so one of the marker in older adult that is the most closely related to cognitive decline, in babies, newborn, it's actually super increased. So really suggesting that it is possible to have an elevated, blood biomarker result that might not be due to Alzheimer's disease processes. But that being said, still overall, the blood biomarker perform extremely well at detecting cognitively normal individual who will decline over time. And they can detect people up to 10 years before they will decline. While for the PET biomarker, if you're positive, then you're really close to progression. Let's start about the challenges about the PET biomarker, right? So the PET biomarker are, again, extremely good at identifying people who will develop cognitive impairment, but they're expensive and they need really kind of a specialized setup, right? Like you need to have a PET scan. So in Canada, for example, it's going to be extremely hard to do, even in cognitively impaired individual, it's going to be almost impossible actually to start doing PET scan, right? While the blood biomarker, we can do a parallel with vascular health, right? Where you can have a panel of marker in your blood. So you can have a panel of marker in your blood to look, for example, at your risk of stroke, looking at cholesterol level and things like that. And then, so I think that we can also have a panel of marker in our blood to look at the risk of Alzheimer's disease. Because in these blood biomarker, you look at amyloid, you look at tau, but you can also look at marker of neurodegeneration and marker of inflammation. So I think that, these markers, when pulled together, they are extremely interesting. And I think that moving forward in the clinic, it's probably going to be possible to do a panel of marker and then identify people that are at high risk of having Alzheimer's disease. The one that should really kind of be, we should try to intervene, but it's kind of like people to watch out, right? And then the one that would be on the OK zone. So when you're positive on the PET biomarker, so ApoE4 increase your risks of getting Alzheimer's disease. Being a female sex, a woman, you are at increased risk as well. So these are two of the main risk factors with older age. But when you are positive on the PET biomarker, at that time, we're pretty sure that you have the pathology related to Alzheimer's in your brain. For the plasma biomarker, this can be other information that can help us, decide what's kind of the risk based on the blood biomarker. But I think that, so if I could rephrase the question to kind of a little bit differently, I think that if we think about, because where do you want to go with that? We want to identify people for preventive trial, right? And then eventually we want also to have a treatment for, to really help people to slow down the disease even before the cognitive impairment. So I think that the one thing that we need to put also more emphasis on is trying to understand why female and ApoE4 carrier are more at risk, right? So if we can try to understand, so the ApoE4 allele is the ancestral allele. So in evolution at one point, it was a good thing to be an ApoE4. However, now it's a risk factor. So how have it become a risk factor, right? So I think that in terms of prevention, these are the type of question that we should ask ourselves. Another thing that I was discussing in the plenary is that we know now a lot about the preclinical phase of the disease, but we don't know why people start that phase, right? Like what brings a person from being from normal aging, whatever that means, to being in the preclinical phase of the disease, right? And then if you look in terms of years of age, So the preclinical phase of Alzheimer's disease probably start within the 50s, and this is exactly the age at which women usually have their menopause transition, right? So one of the things that we discuss is it possible that the changes happening in menopause, such as change in glucose metabolism, change in insulin, vascular factor, could that put kind of like the stage to help the protein get together, and then could that facilitate actually the start of Alzheimer's disease? So I think that these research questions are what we should be asking.